Hi, it's Dr. Noel Williams, Optimal Health Associates, January 30th, 2021. COVID update. So, still out there, still occurring. Case numbers are coming down. Some of that's probably the vaccine. Some of it's a little bit of population density in terms of so many people have gotten infected. But overall, still going on. We're at 453,000 deaths. So still a bummer. But I think overall, a lot of positive news, even though it's going against the media narrative and potentially some comments from the government, but not from people who seem to know the most, even though sometimes I think they're confusing and have been wrong. But we'll start with Frank Collins, who's head of the NIH, who I think has been a disaster. But he very clearly this week was talking about immune rates and vaccine effects, and he seemed to feel really comfortable that we were on track to get herd immunity. There's differences in numbers between what I'm looking at and what he's looking at, but he is the PMD who's in charge of the NIH, but they are alarmists. So he's saying 85% for herd immunity. I still think it's more 75, but be that as it may, he thinks we're on track for herd immunity in the next, 6 months, basically, if we get the vaccine rolled out appropriately, and they're very optimistic. That he didn't seem even vaguely overwhelmed about the variants, which I'm going to get to, and we're going to talk about what a variant is on the spike protein and what antigens are, which are proteins, and we'll go over that in a little bit. But that seems to be the bigger news right now is these variants in South Africa and the variants in Brazil. Keeping in mind that this is now round 4 or 5 of variants. We've had them in the Netherlands, and oh my gosh, they were going to make neutralizing antibodies ineffective. And then it was England. And that's just not been true. And if we look at the science from the preliminary science from South Africa and Brazil, it's not true either. What they're seeing, though, is there is some changes in convalescent plasma neutralizing antibody in the petri dish or the lab for neutralizing the viral protein. Well, that's not super important, first of all, because we already know convalescent plasma wasn't like a total miracle. It's been helpful, but it's been really hit or miss, and I think there's been a lot of arguments about it scientifically, but ultimately it's been a little helpful, but not super helpful. Because antibodies are just one part of your immune response. So when we look at the variant in South Africa and we look at the variant in Brazil, there is one case report of reinfection from the South African variant in Brazil. There's one case report of the Brazilian variant reinfecting someone in Brazil. Both variants have been around for more than 6 months. So they have been circulating through the populations in Brazil and South Africa. Brazil has several million COVID positive people. South Africa has about 1.5 million COVID positive people. Huge numbers of those were COVID positive before the variants came around. So what does it tell us if we have no documented reinfections in South Africa to the variant, and we only have one case of the South African variant reinfecting someone anywhere in the world, and that's in Brazil, and one Brazilian variant reinfecting one person in Brazil? They're one-offs, okay? They're going to happen again. There's going to be isolated reinfections because some people don't amount that great of an immune response to a vaccine or to an infection. But the thing we're not seeing, and this is the important point because this is population health, it's not individual health. It's trends to follow. There are not case clusters of reinfection anywhere so far. There would be some. There would have been some in the Netherlands. There would have been some in England when they had their variants. There would have been some in South Africa, and there would have been some in Brazil if these variants were really going to be causing lots of reinfection. Or if the vaccines that, at least the Pfizer and Moderna, which are the only two I'm ever talking about when I'm talking about successful vaccines, there would be case clusters of those people turning up. There isn't. And why is that? Well, because real immunology in the body is much more complex than a petri dish. And if you just look at the data, so this is the spike protein. The neutralizing antibodies we've been talking about bind here. If there's variations in the proteins here, they may not bind as well, just like there's other spots where neutralizing antibodies can bind through here. It turns out these variants have changes through here and here where the binding isn't as intense, But interestingly enough, non-neutralizing antibodies in the paper I read, which was one of these lab papers today, that had not been neutralizing on the existing COVID, but antibodies people developed, were neutralizing on the variants. So kind of a complex subject, but so you make lots of antibodies to a virus. Some of the antibodies are going to neutralize it. Some of them are not going to be that useful. Well, it turns out some of the not useful ones with what we've had may end up being really useful against the variants. So it ends up being a jambalaya of effects for your adaptive immune system. And we're always ignoring plasma cells, and we're always ignoring T cells. And I mean, the T cells react within a few hours at most, directly quoted from an immunology paper on adaptive immunity from T cells that I read today, because I read a lot of immune papers today. Oh, God, not exactly the most fun subject, but at least a little interesting. And so we have T cell adaptive immunity that is lifetime often for viral infections. And then we have antibodies that are going to be produced because we have our germinal B cells, even if your antibody levels have gone down. So the sum total of the variances, it's much ado about nothing so far. I'm not saying that may not change. I'm not going to, because science changes and it evolves. But currently, based on all the data, this is nothing but fear. And I think part of it is, and this is where it gets, I think, very interesting and convoluted, the mutational variants, guess what they do probably affect? The mutational variants look like they affect the big pharma antibodies that are being produced that are the next generation. That if someone gets COVID and you give them the antibodies that are in development, those ones are where the mutations on the side, per se, may play a role and render the big pharma ones ineffective. That doesn't mean the current one that we're using in the United States, whose acronym I can't pronounce, isn't going to change because it's at the tip, but the future ones may be off. And that may be one of the reasons that everybody's getting Twitter pated scientifically, is there's a lot of money at play for these ones. That has nothing to do with our own immune systems. So I think we have to really be careful about the fear factor and getting overwhelmed, because it's just, the science is just not there to show that we need to be scared. It's not there. It's not there. I will let you know. I mean, I did all different types of literature searches. I finally went from PubMed to Google and put case reports of reinfection anywhere in the world, case reports in Brazil, case reports in South Africa. I could find 2 scientifically, the 2 I mentioned. That's it. I mean, so we're just not seeing that. So I wouldn't worry about it that much. If I was, if you're a normal person, worry more about driving in a car accident than anything having to do with COVID variants. It is a giant waste of time. There's a few here, they may spread, but if you've had COVID or if you've had the vaccine, I would not worry about it at all. If you haven't, or if you've had, I still want you on your zinc. I still want you on a multivitamin. I still want you on your vitamin D. I still want you taking your melatonin. I want you to do all the things we've listed, because that's going to also help you against all viruses, not just COVID, but influenza and cold viruses and potentially other viruses. So you want your immune system ratcheted up. So that's kind of the summary. So let's talk about vaccines for a second. So vaccines, the thing with the vaccine is you get an immune response, usually. And it's looking like in the data, 95% of the people have an immune response and develop immunity. That also means 5% don't. So thinking about the infection, some people too are not going to get immunity from the infection. It's going to be a small number. But the vaccines do provide 95% immunity rates. And that means you're immune, you don't get it, you don't spread it. That's what immunity means. That's what it's always meant. That's what the Pfizer paper said. Okay? So any of this other stuff about, oh, you could still transmit it or something. Nah. Yes, if you touch a doorknob that someone who just coughed in their hand who has active COVID and you touch it, you will momentarily carry that. That's not what we're talking about. There's always contact spread. No one can avoid that. But in terms of you being an active carrier and infected and spreading it, it's just not happening. okay? And one of the reasons I think they bring this up is it's not provable either that you'll ever avoid it, because once you have antibodies, you have antibodies. I mean, so they can't show that you've gotten reinfected or not reinfected, because that's the whole point of this argument. So it drives me a little bit nutty. Uh, if you don't, so one thing that people want to know, are they immune after their first antibody injection? Generally, you're going to probably be immune in 10 to 12 days. But there's going to be some people that are going to need the second vaccine. Why? Well, one, sometimes the vaccine, the first one you get, since they're going to be they're giving millions and millions and millions. Let's be realistic, folks. Some of them will not be good. Some of them will have gotten too warm. Some of the injections will be given wrong. It's just the nature of how things work with humans. Okay, so the second one's going to cover a lot of, two going awry is pretty rare. So the second one's going to help. The vast majority of people respond to the first vaccine. If you look at the antibody levels I've shown, it's very clear that they do. But that's why we encourage the second vaccine. Next, should you get the vaccine if you've had the infection within 3 months? I don't think so. I'm an outlier on that. I think if you were hospitalized, you want to wait at least 4 months, because you could turn on cytokine storm is a concern. A cardiologist just wrote a paper to the FDA about all of this, highlighting basically in more in-depth some of the things I've been concerned about. If you're already infected and then recovered and immune, then getting a big dose of antigen close to that may cause some problems for you. So why do it? You're immune already, almost always. So at this point, I'd go with 3 months if you got sick or infected, and I'd go 4 months if you're in the hospital. You can talk to your own providers about what they're going to tell you to do about getting shots. Most of them are just going to say, get the vaccine. That's totally up to them. But I would go 3 months and then 4 months, depending on how sick you got. And if you want to wait longer, as I have people in my staff, since we spend a lot of time talking about this, who are going to go longer. They're not going to get the vaccine probably for 6 or 9 months, because they've just from reading all the papers that I've sent them. But you know, that's your own self, and they're medical people, and so they make their own decisions. So what am I missing, Kim?
You've hit almost everything I had written down. Did you want to talk about double masking, or did you already talk about that?
No, double masking's stupid.
Okay.
Jeez. I mean, double masking's stupid. You got to be able to breathe. You need to breathe. Breathe. If you hit, I mean, double masking, I mean, the data on single masking, while helpful and beneficial, isn't at the point where it's black and white anyway. And number two, but I think it's good data, and I always encourage single masking. Double masking, no, come on. That's just silly. And coming from the biggest liar in America, you know, it's really hard to understand.
Okay.
And that'd be Fauci.
Do you want me to go to questions?
Yes.
Okay. So a couple of people have said that they're at high risk for DVTs.
Yeah, deep venous thrombosis, getting a blood clot in one of the big veins.
So, and they know that COVID can be causing clotting issues. Are they safe to get the vaccine, since the body will think they have?
Currently, the combination of events that lead to blood clot is inflammation in the blood vessel, plus changes in what we call cytokines, notably potentially interferon gamma. There's a slight rise in interferon gamma with a vaccine, at least in one paper I saw, but there's no associated inflammation in your vascular system. There's no data showing in the vaccinated group any change in deep venous thrombosis. So at this point, I think it's fine if you have a history of deep venous thrombosis or at higher risk to get the vaccine. But again, I'd always have you on fish oil before you do it, just because if you have any elevated risk for blood clot, you always want to be on fish oil or essentially a baby aspirin, but talk to your provider about that before getting the vaccine.
Okay. So because we've heard of a couple of people like this. So they got their vaccine, and then 3 days later, 4 days later, turns out they have COVID, so they test positive.
Right.
Should they still get the second one on track with the first vaccine, or wait longer?
So the question is, should you get your second vaccine if you unfortunately were infected as you got your first vaccine, or got infected shortly after your first vaccine because you didn't have time to get immunity? That's a great question. I think the common sense answer scientifically would be you would wait. I would encourage you to wait at least 3 to 4 months. The FDA opinion is probably go ahead and get it. I mean, it just depends on which group you want to follow. I'm an individual person who reads and applies common sense to clinical decision making. So I think if you have the infection and got the vaccine, the chances of you not having a super brisk immune response would be very, very teeny tiny. I would encourage you to probably get the second vaccine eventually, but the last thing on earth I'd want you to do is get a second vaccine that then backfires and you get super sick, which is a strong theoretical concern. So that would be my opinion on that. Even though it differs from umbrella medical organizations, you can talk to your providers about it. They're going to probably just toe the standard lines.
So if you've had the virus, why would you get the vaccine? This person's wondering, do the vaccine antibodies last longer than the natural ones?
So the question is, do the vaccine antibodies last longer than the natural ones? The first answer to that question is we don't know. The second part of that is we know the antibody levels with the vaccine generally go higher than the convalescent plasma levels of antibodies. Okay, because the first vaccine is going to get 95% of people under the age of 55 to that same level of convalescent antibodies. If you're over 55, you're going to hit the level, but you're not going to go over. If you basically, or you may go over, I want to say that a lot of people go over, but it's some of you may not get as high. When you get the second level, the majority go as high or higher is the bottom line. So your antibodies are going to go higher on average from the vaccine than you do from the illness. But does that really matter? Is antibody titers that important? And that's the big question. I don't think they are, and that's what the current immune papers show, and there's long-term immunity even with mild infections with low antibody levels. But that's my opinion from reading journal articles. I don't have an explanation for, well, I do, but the FDA, CDC, NIH view of this is totally different because they just want everyone vaccinated and don't want to worry about, because they're doing large bulk medical care with this. They don't really care. They want everybody vaccinated, and if there's a few people get sick and even die from it, that's kind of in the calculation in their minds to expect. So I don't know, did I answer that? I kind of did, I kind of didn't. I mean, the bottom line is if you got infected, you are probably immune. I really firmly believe that. I mean, there's going to be one-offs. Again, it may be 95% of you are immune that have been infected long-term, and 5% won't be. Something in that range. So, if you get one booster and you check your levels 3 weeks later and they're sky high, do you need either one more? I don't think so. But again, the only reason they did the second vaccine was really because of the over 55-year-olds, and it was a theoretical concern. Because if we were really going to do this correctly, what we would have done is we would have given everybody one vaccine. And everybody who responded, you would then look at how did their B cells mature and their T cells mature from the vaccine over the next year. Well, we have some of that data from the infected patients, even with mild infection, and they have long-term immunity present in their bone marrow, essentially. So it would be shocking if after one vaccine you didn't. But again, it gets all very convoluted because I don't know how else to explain it. The bottom line is you're almost always immune if you got infected with the current data. You're almost always immune with just one vaccine with the current data. But the FDA is recommending 2. And if they're recommending 2, they're recommending 2. I was happy to do 2 because I wanted to make sure my antibody levels were sky high, and they were. And so I feel like I'm done. I'm not worried about the variants. I'm not worried about any of it. I take my vitamins, my supplements, and I'm done with COVID for me. I mean, I'm not for everybody else, but for me. One of the things we'll get to, I think, later this week will be the long haulers. We're seeing a lot of people with fatigue and lung damage and brain fog and all of that. So we'll address that later in the week.
Do you have any suggestions on how to get your taste and smell back?
There is no treatment regimen for that at this point. There's some theoretical things you could consider. You could think about some nanoparticles, stem cell stuff. I mean, it would just be, it'd be totally experimental to do it, but it's still allowed by the FDA. You do what's it's called, a umbilical cord tissue derived, minimally manipulated mesenchymal stem cells from umbilical cord tissue. You get nanoparticles and you infuse them IV, and they can rehabilitate stuff. But that's a total experimental therapy. We call it exosomes, but exosomes is now considered a pharmaceutical name for something scientific, which the FDA is crazy because they've made a scientific expression of a drug. So those types of umbilical cord tissue, minimally manipulated mesenchymal stem cell derived products might be reinvigorating for that.
That's all I have.
But I don't know if they are. I want to emphasize it's just, I mean, when you're talking choices for this stuff, it's tough. The other thing you could probably do that's more natural is lipoic acid. Lipoic acid can heal. If you kind of look at it like herpes, that the inflammation in herpes or shingles causes the nerves to get really inflamed and they lose their myelin sheaths, so then they can't transmit very well the nerves, and so it can cause pain or numbness or whatever. Perhaps that's part of the problem with the change in taste and smell, but we don't know the exact. But lipoic acid is something we use to help with that healing, or with if you're getting chemotherapy from Cytoxan or cyclophosphamide, we'll use lipoic acid to protect people, and there's some data supporting that. But again, it's a tough situation. These long-term symptoms are tough. Okay, so take home. Don't worry about the variants. Worry about driving. Okay, if you're riding a bike, wear a helmet. I mean, that's the stuff to worry about. Don't worry about the variants, and then get your vaccine and take your supplements. Good night.